Hello everyone, and welcome to the Clinical Pharmacology YouTube channels. I am Dr. Khalid Hassan, Associate Professor of Clinical Pharmacology. Today we are going to speak about the clinical pharmacology of gastrointestinal system, and we are going to cover several topics in this session. So, topic that will be covered in this section, we are going to speak about peptic ulcer disease, GERD, gastroesophageal reflux disease, nausea and vomiting, constipation and diarrhea, and some other gastrointestinal disorders such as IBD, IBS, which stand for irritable bowel disease and irritable bowel syndrome. So as you mentioned, today we are going to speak about peptic ulcer disease. So speaking about peptic ulcer disease pharmacology. So peptic ulcer disease may be defined as a disruption in the mucosal integrity of the stomach and or the duodenum. This will lead to the local defect on the mucosa and excavation. A patient may suffer from abdominal pain, epigastric pain, nausea, vomiting, loss of appetite, heartburn, and bloating. A patient may come to the hospital or emergency room with a complication of peptic ulcer disease, such as bleeding. We have obstruction and perforation. All these complications may require surgery. Before we go in depth about the peptic ulcer disease, we need to treatment. So before we start speaking about the pharmacology of peptic ulcer disease, we need to understand the physiology and pathophysiology of GI system, and especially the stomach and the intestine. As we all know that we have three main pathways affect the GI system, and the first pathway we call this one neural transmitter. So we have neurons there, and this neuron release acetylcholine. So the first neuron, parasympathetic neuron, release acetylcholine, and this acetylcholine stimulate muscarinic receptor M3 receptor. Then we move to the endocrine transmitter. This type of cells release gastrin, and this gastrin stimulate CCK2 receptor, which stands for calcitonin receptor. So again, this stimulate calcitonin receptor. And we have another major effect with the paracrine and adjacent cells. This adjacent cells called enterochromaffin cells, and this cells release histamine. Histamine stimulate H2 receptor. H here stands for histamine, and as you can see here, what type of histamine we have here? We have H2 receptor, and we need to remind you we have H1 and we have H2. So the H1 mainly involved in allergy disease, all allergic disease. H2 mainly available in the GI system and involved in peptic ulcer disease. So allergic disease here we talk about antihistamine, anti-allergic drugs. Okay, so you can, from what we have in the beginning, we have three main mediators there, but we have another maybe mediator number 4 here. We can add this one here, number 4. We have another component on the stomach, and this component called prostaglandin, and we are going to speak about prostaglandin later on. Okay, speaking about the etiology of peptic ulcer disease, the causes of peptic ulcer disease, this could be related to the bacterial, and this bacterial called Helicobacter pylori. Okay, could be bacterial Helicobacter pylori, and they found to play important role in peptic ulcer disease. Could be related to the stress, and you can see here stress may cause peptic ulcer disease, and this is considered like acute case. And another issue here, we have some important factors, NSAID, nonsteroidal anti-inflammatory drugs. So you can see here we have three main factors or possible causes of peptic ulcer disease. Number 1, Helicobacter pylori. We talk about bacteria here. Number 2, we talk about stress, anxiety, may cause acute ulcer disease, and medication drugs, and the most popular drugs will be NSAID. We have some aggravating factors, could be emotional stress, smoking, alcohol, and drugs. So we have some other factor may aggravate the situation. This slide briefly discusses causes, symptoms, and diagnosis of peptic ulcer disease. As we mentioned, we have three common causes of peptic ulcer disease. We have Helicobacter pylori, NSAID, or stress-related. Patient may come to the clinic suffer from abdominal pain, heartburn, could be pain in the GI system 1 to 3 hours after eating. And if you speak about duodenal ulcer, if you talk about gastric ulcer, the pain associated with eating. So here, when the patient take food, they start suffer from pain. With the gastric ulcer, with duodenal ulcer, they said pain start after 1 to 3 hours of eating. Okay, or after eating. So moving to the diagnosis here, we move to the best way to perform an endoscopy to the patient. During the endoscopy, if we found the ulcers there, we recommend to take biopsy, and the biopsy to maybe identify or exclude the availability of Helicobacter pylori. So endoscopy and biopsy. We have some other tests for H. pylori, and urea breath test, for example, we can do it for the H. pylori. So endoscopy, biopsy, urea test, and we have other tests could be used for diagnosis, and this will be explained in details in other courses. So as you can see here, we have causes, we have symptoms, and then we have diagnosis. Okay, so in order to understand how the NSAID drugs or other drugs may affect the gastrointestinal system and cause ulcers, we need to look on the physiology and what happened in the GI system. Then we move to the medication, apply our medication in this system. First, if you look on the cell membrane, and the cell membrane here we have cell membrane, and then we have double layer of lipid here and membrane. And the cell membrane here, we have something called membrane phospholipid. And you can see the membrane phospholipid here under the effect of enzyme called phospholipase A2 will be responsible for synthesis of arachidonic acid. Arachidonic acid has two main pathways. The first main pathway called lipooxygenase. So the first pathway called lipooxygenase, and the second pathway called cyclooxygenase. So as you can see here, if you talk about if you speak about arachidonic acid, talking about arachidonic acid, we have two main pathway. We have lipooxygenase and another pathway called cyclooxygenase. So we have two main pathways. Lipooxygenase is responsible for synthesis of leukotriene, and cyclooxygenase is responsible for synthesis of prostaglandin. So this one, for simplicity, arachidonic acid, we have two main pathways. The first pathway involves enzyme called cyclooxygenase, and the abbreviation COX, and the second enzyme lipooxygenase, and abbreviation LOX. The cyclooxygenase ended up with the formulation of prostaglandin, and lipooxygenase will lead to the formation of leukotriene. So for example, leukotriene is already covered in the topic related to the asthma, for example. We cover this one in the asthma and COPD, and I refer you to that lectures, which is available already on YouTube. Okay, speaking about COX, cyclooxygenase, and formation of prostaglandin, you can see here from the graph or the image here what we have. Arachidonic acid, we have two types of cyclooxygenase. We have cyclooxygenase 1, as you can see it here, and then we have cyclooxygenase 2. So they said cyclooxygenase 1 is considered like housekeeping. It's very important, responsible for physiological action. So COX-1 responsible for physiological action. Please remember that. So homeostatic, responsible for physiological actions. This enzyme will lead to the formation of prostaglandin. Several types of prostaglandin, could be E1 or E2 and other prostaglandin, and the most important prostaglandin called thromboxane A2. So you can see here we have prostaglandin in general, thromboxane A2, the most important one. Then move what target, what organ will be affected with this type of enzyme of prostaglandin. They said if you talk about the GI system, if you talk about the gastrointestinal system, stomach and intestine, prostaglandin has a gastroprotection effect. So prostaglandin protect the GI system, gastroprotection. This is our topic here. So we need prostaglandin to protect our stomach. Prostaglandin also involved in the renal function. Okay, prostaglandin, thromboxane A2, this type of prostaglandin lead to the increased platelet aggregation and vasoconstriction. And this topics covered already in the maybe lecture related to the anti-platelet. Okay, so we covered this one in the antiplatelets. This is not our topic today, but we are focusing on the GI system. So the topic now, prostaglandin has gastroprotection effect on the GI system. This is an important one. The question now, you can see here that we have first type of enzyme called cyclooxygenase. They said, okay, on the other hand, our body lead to the formation for another enzyme called cyclooxygenase 2. And cyclooxygenase 2 responsible for synthesis of type of prostaglandin in general, several type, and one of the most important one called the prostacyclin. Okay, so COX-2 lead to the formation of prostaglandin. This prostaglandin responsible for pain, fever, and inflammation. Okay, so I'm going to focus on the GI system now, not on the blood disorder, for example. So you can see here cyclooxygenase responsible for specific formation of prostaglandin. This type of prostaglandin, COX-2 prostaglandin, you can see we have pain, fever, and inflammation. Okay, this is the reason why some patients, if they suffer from pain, they take ibuprofen, or they take naproxen, or they take like meloxicam or celecoxib. Okay. Okay, so now we try to apply medication here. You can see here, for example, if the patient suffers from headache or like muscle pain, and the patient start using ibuprofen. So the patient start using ibuprofen or naproxen. Okay, ibuprofen, naproxen inhibit. You can see it here. This medication belongs to something called non-steroidal anti-inflammatory drugs. And they said this type of NSAID work through the blocking cyclooxygenase 1 and cyclooxygenase 2. And you can see it here. Okay, ibuprofen, naproxen block both COX-1 and COX-2. Okay, if you look on the COX-2, when the ibuprofen or naproxen block COX-2, this will lead to the inhibit synthesis of prostaglandin, and the end result will be relief pain, relief fever, and reduce inflammation. That's great. This is what we need from medication. Ibuprofen, naproxen, relief pain, reduce fever, and reduce inflammation. That's great. On the other hand, this NSAID, ibuprofen and naproxen, also inhibit COX-1. And COX-1 responsible for prostaglandin formation, which is responsible for gastroprotection. So when you inhibit COX-1, we omit or delete the effect of prostaglandin as gastroprotection. And on the stomach, we have other factors considered like aggravating factors may expose the mucus to the maybe harmful factors such as pepsin, such as gastrin, such as hydrochloric acid. So we have other factors, but when you inhibit this COX-1, the result will be irritation to the GI system. Okay, this number one. And what about glucocorticosteroids here? They said, okay, glucocorticosteroid also inhibit and decrease, glucocorticosteroid inhibit and decrease prostaglandin, but with the other mechanism. They said for glucocorticoids or cortisone, prednisone inhibit enzyme called phospholipase A2. So you can see here phospholipase A2 is enzyme required to formation of arachidonic acid. So when the arachidonic acid inhibited, the result will be inhibit COX-1, lead to the decreased formation of COX-1 and COX-2. For this reason, we use it like corticosteroid as anti-inflammatory, number one. And at the same time, they found is okay, this medication may cause ulcer. Okay, so glucocorticosteroids. But they start talking about what is a percentage, how much, if you talk about clinical research, for example, if you prescribe a glucocorticosteroid for to 200 patients, for example, what is the percentage of patients will suffer from peptic ulcer if they treated with a cortisone? They found it's only 2%. So we have low percent of patients may suffer from peptic ulcer disease. If you compare that with the ibuprofen and naproxen, we have large percent compared with the corticosteroids. Okay. Okay, so here we have practice question. The practice question here, they said ibuprofen contribute to the peptic ulcer disease by decreasing production, which of the following endogenous agents? We have histamine, we have gastrin, prostaglandin, acetylcholine, and serotonin. So we have ibuprofen. So when you read it, okay, we have ibuprofen here, and we know ibuprofen belongs to the NSAID. Okay, the ibuprofen lead to peptic ulcer disease by decreasing which of the following. So we're looking for maybe mediator by decreasing by the NSAID. Histamine decreased? No. Gastrin? No. Serotonin, acetylcholine. So the correct answer will be prostaglandin. So the correct answer for ibuprofen decrease formation of endogenous substance and lead to the peptic ulcer disease. Okay, which of the following are common causes of peptic ulcer disease? Select all that apply. I will start from last one. Cirrhosis, yes or no? If you said no, you are correct. Okay, Crohn's disease, yes or no? Popular common causes of peptic ulcer disease, no. Viral infections, no. What about emotional stress? Yes. What about NSAID? Yes. And Helicobacter pylori? Yes. Zollinger Allison? No, it's not. It's rare. Could be caused, but it's rare. Rare cases. So you can see the most common popular causes of peptic ulcer disease: Helicobacter pylori, NSAID, and emotional stress. Okay. So as you can see here, we try to maybe explain briefly about the symptoms. Patient may come to the clinic suffer from abdominal pain. Patients suffer from heartburn or nausea, vomiting, and anorexia. Some patients suffer from weight loss in addition to the nausea, vomiting, and anorexia. Patient may come to the hospital suffer from complication of peptic ulcer disease such as bleeding, perforation, and obstruction, and sometimes this ulcer may convert to the gastric ulcer. And we discuss how we diagnose the patient by using endoscopy and take biopsy to confirm or exclude the peptic ulcer disease. They said endoscopy, upper endoscopy, maybe confirm the 90% of the peptic ulcer disease. And we have urea test, urea breath test, and other tests could be used for diagnosis of peptic ulcer disease. Okay, which of the following represent the complication of peptic ulcer disease? Select all that apply. Complication of peptic ulcer disease. Okay, abdominal pain, obstruction, heartburn, nausea, vomiting, bleeding, perforation, GI cancer. Complication of peptic ulcer disease: abdominal pain, yes or no? Obstruction, yes. Obstruction, yes. Heartburn, no. Nausea and vomiting, bleeding, perforation, yes. GI cancer, yes. So you can see here we have some, maybe you can see it in that what we have here. These are the complications. So abdominal pain is not complication. Abdominal pain, signs, symptoms. Okay, this is sign and symptoms here. Obstruction, bleeding, perforation, and cancer. So if you are interested in learning more details about the situation, please you can maybe click on the link and read on more information about peptic ulcer disease. Okay, moving to the pathophysiology. Speaking about peptic ulcer disease pathophysiology, before we move to the pathophysiology, we need to learn what happened in the normal healthy individual subject. So they said in normal healthy individual subjects, in normal healthy individual people, there is a balance between two factors. We have defensive factors and then we have aggressive factors. So in our stomach, we have two main factors. We have defensive factors protect our stomach, and we have aggressive factors may cause peptic ulcer disease. This will lead to the peptic ulcer disease factors, and this will protect from peptic ulcer disease. So the defensive factor protect from peptic ulcer disease, and aggressive factors lead to the peptic ulcer disease formation. Okay, so speaking about the defensive factor first, what factor may protect us from the GI peptic ulcer disease? Number one, mucus. Mucus production protect us from the peptic ulcer disease. So mucus production, bicarbonate, because we talk about acid cause ulcer, bicarbonate protect from ulcer, prostaglandin, that's great, blood flow. So all these factors are repeated: mucus production, bicarbonate, prostaglandin, blood flow protect from peptic ulcer disease. Protection factors, defensive factors, mucus, bicarbonate, prostaglandin, blood flow. What about the aggressive factors or excessive factors may lead to the aggravate the situation? So what we have here, we have acid. So if you have acid, there is a risk of peptic ulcer disease. If you have increased secretion of pepsin, there is increased risk of peptic ulcer disease. If you have bacteria, just as Helicobacter pylori, there is a risk of peptic ulcer disease. Carcinogenic drugs, when you speak about NSAID, NSAID cause peptic ulcer disease. Stress, psychological factor. When you have stress, for example, this will lead to the peptic ulcer disease. So we have balance. You can see the scale here. You can see the scale, and we have balance between defensive factors and aggressive factors. Here we need you to remember which factor protect, which factor may cause peptic ulcer disease. So acid, pepsin, Helicobacter, stress, drugs, medication, cause, and mucus, bicarbonate, blood flow, prostaglandin protect from peptic ulcer disease. Okay. In patient with the peptic ulcer disease, what happened? They said we have an imbalance. There is an imbalance between aggressive factor and defensive factors. You can see here the aggressive factor overcome the defensive factors. We have more acid formation, more pepsin formation. We have bacterial infections, for example, could be drugs, could be stress. So any of these factors may overcome the defensive factor and cause ulcer. And you can see the scale here, like we have overcome of aggressive factor. We have an imbalance between the aggressive factor and defensive factors. Okay, moving to in order to understand what happened in the GI system. Okay, so what we have here in order to understand what happened in the GI system, you can see we have two main parts. We have antrum and we have fundus for the GI system. When you speak about the GI system, okay, so we have the fundus and then we have the antrum here. And in the antrum, we have two types of cells. As you can see it, we have G cells and then we have D cells. And we have G cells and D cells. So the G cells, as you can see, responsible for formation of gastrin. And the D cells responsible for formation and release of somatostatin. So in the antrum here, responsible for two types of mediator, somatostatin from D cell, gastrin released from the G cells. Somatostatin under the effect of acid will be released, and this gastrin will be released under the effect of dietary food. Okay, so what we have here, we can look on some maybe a process there is very important. Okay, so what we have here, somatostatin, the green circle here, this is a somatostatin. The somatostatin released from the D cells. Okay, somatostatin, when the somatostatin released from the D cells, what happened here? Somatostatin will affect the gastrin. these G cells and inhibit release of gastrin. Somatostatin considered like inhibitory hormone. So somatostatin is hormone. So when somatostatin release from these cells, this will lead to the inhibitory effect on the gastrin, inhibit secretion of gastrin, somatostatin. Okay, if you don't have this effect here between the GI system, only we have stimulation of G cells will produce gastrin. Gastrin is a type of hormone. Gastrin released from the G cells enter the blood. You can see it in the blood here, gastrin moving on the blood. Okay, that's great. And until arrive to the fundus. Okay, this place here arrive to the fundus. You can see the gastrin, and then gastrin bind to the receptor. This receptor called gastrin CCKR, calcitonin receptor. So gastrin bind to the calcitonin receptor. This will lead to the stimulation of histamine fiscals. Okay, the histamine fiscals and enhanced release of histamine. And this cells called ECL cells. And ECL stands for enterochromaffin cells. So you can see here we have four main cells in the beginning. Number one, okay, we have four main cells there. Number one, we have G cells produce gastrin. We have D cells produce somatostatin. Enterochromaffin cells produce histamine. And then we have parietal cells. This is produce the acid. You can see the proton here. So we have four main cells involved in the peptic ulcer disease. Number one, G cells, gastrin. D cells, somatostatin. Enterochromaffin produce histamine. And parietal cells produce the proton. Okay, so you can see here, as we discussed, the gastrin release from the G cells, enter the bloodstream and going to the enterochromaffin cells to induce and release of histamine. Okay, not only gastrin here affect the histamine. They said we have another factors may release histamine. This factor is called acetylcholine. Acetylcholine is like released from the neurons. We have some neurons release acetylcholines. Okay, this coming from autonomic nervous system. Okay, autonomic nervous system neuron release acetylcholine in the enterochromaffin cells. We have receptor related to the acetylcholine. This receptor called muscarinic receptor, and we have a specific type of muscarinic receptor called M3 receptor. So M3 receptor will be activated. So acetylcholine will activate M3 receptor in the enterochromaffin cells, and this will lead to activate release of histamine. So you can see here we have muscarinic receptor activate histamine release. We have gastrin activate histamine release. We have several factors maybe lead to the activation and release of histamine from the cells. Okay, so now the second step, you can see it here, release of histamine. This is the second step. So releasing of histamine. When the histamine released in the between the cells, the histamine will bind to the histamine receptor. What type of histamine receptor we have in the parietal cells, H1 or H2? What do you think? So if you said H2, you are correct. So H2 receptor will be available in the parietal cells. Okay, H2 receptor. Okay, this is number one. Again, what happened there? We have M3 receptor muscarinic, and we have, they said, okay, you can see the acetylcholine, also acetylcholine activate and stimulate M3 receptor in the parietal cells. And okay, so acetylcholine stimulate muscarinic receptor in the parietal cells. In the parietal cells also we have a gastrin receptor. So gastrin receptor here will be activated. So from these cells here, the parietal cells is most important. Our target for treatment will be parietal cells. So this is our target, parietal cells. How many receptors do you have in the parietal cells? We have four main receptors, as you can see here. We have muscarinic receptor, M3 receptor. We have histaminic receptor, H2 receptor. We have gastrin receptor. And receptor number 4, we have prostaglandin receptor. So we have four main receptors available in the parietal cells. I will repeat it. Muscarinic receptor, histaminic receptor, prostaglandin receptor, and gastrin receptor. Okay, all these receptors, when it's activated or inhibited, will interfere with the proton pump inhibitor, with something called proton pump. Another name, proton pump. So another name could be hydrogen potassium ATPase. So you can see here we have several steps to release acid from the GI system. So we need you to remember from this graph here what type of cell will be involved and what is the effect of these receptor on the cells. The next slide will discuss the effect of these receptors, the effect of these 4 receptors on the production of acid in the GI system. What is the effect of these receptors on the acid production in the GI system? Okay, so you can see here, as we discussed, we have acetylcholine or acetylcholine, then we have histamine, then we have prostaglandin, and we have gastrin. Okay, I will start with the first one. Sorry. So acetylcholine bind to the M3 receptor. M stands for muscarinic receptor. Activate and enhance something called deacylglycerol, IB3, and this will lead to the formation of calcium. Increased calcium will activate protein kinase. Activate protein kinase will stimulate the proton pump and increase release of acid. Okay, number 1. Acetylcholine bind M3, increase calcium concentration. This will lead to the activate protein kinase and activate, and the end result will be stimulate or activate proton pump and release the proton, release the hydrogen. Hydrogen at this space here will be conjugate with the chloride and cause hydrochloride in the GI system. Okay, this number 1. Number 2, similar pathway. We are going to speak about similar pathway here. The similar pathway will be gastrin. Gastrin bind to the gastrin receptor. The same, increase calcium formation. This will lead to the activate of protein kinase. You can see the plus here, mean activation. Activate protein kinase. And this protein kinase will be involved in the stimulation of proton pump or the hydrogen potassium ATPase, and this will lead to the increased release of hydrogen. Okay, gastrin. Then the third one, so you can see we discussed 2 maybe mediators with a similar pathway. Both of them increase calcium. What about other mediator? The other mediator, I will clean this one to make it clear for us. Okay, the other mediator will be the histamine. Histamine bind to the H2 receptor. H2 stands for H2 receptor here. H2 histamine receptor. Histamine bind to the H2 receptor. Okay, this will lead to the activate GS protein. GS protein will enhance conversion of ATP, adenosine triphosphate, to cyclic AMP. Okay, GS activate, enhance cyclic AMP, and enhancing cyclic AMP, this will activate protein kinase, and protein, when the protein kinase activated, this will lead to the stimulation of proton pump and release the hydrogen. Now we can understand, or we can ask question, how histamine release acid in the stomach by activating GS protein, increase level of cyclic AMP, and activate protein kinase. Number 1, done. So moving to the prostaglandin. How the prostaglandin work on the GI system? They said prostaglandin bind to the prostaglandin receptor. So you can see it here. Prostaglandin activate prostaglandin receptor in the parietal cells. This is parietal cells. So please remember, prostaglandin bind to the prostaglandin receptor. Okay, so what happened next? What type of protein will be affected? Okay, GI protein will be enhanced, activated. So GI protein will be activated. When you say GI, I stand for inhibitory effect. So that means when the prostaglandin bind to the receptor, activate GI protein, the result will be inhibitory effect, inhibit adenine cyclase. The result will be inhibit adenine cyclase. Okay, so what happened there? when you inhibit adenine cyclase. When you inhibit adenine cyclase, okay, when you inhibit adenine cyclase by prostaglandin, the result will be decrease, inhibit. So this step will be stop here. Okay, when you have inhibitory effect, that means we have decreased level of cyclic AMP. That means we have decreased activation and decreased secretion. For this reason, they said prostaglandin inhibit effect, decrease secretion of acid. So prostaglandin, the end result will be decreased secretion of acid. Okay, so which of these mediator associated with the decreased secretion of acid? Prostaglandin. Which of these mediator associated with the increased acid? Okay, increased acid. Okay, we have acetylcholine, increased acid, histamine, increased acid, and gastrin, increased acid. So we have only one mediator in this diagram here, in this image. Decreased acid will be prostaglandin. Okay. Okay, we're done now, and now if you look on the diagram here, we can start to predict, and you can start guessing which medication we are going to use to treat peptic ulcer disease to decrease acid secretion. What type of receptor we are going to use? Okay, we can use some medications, and we have a discussion now. What type of medication we are going to use? We can use some medication able to inhibit, for example, acetylcholine. So that will be good. We can use some medication inhibit histamine, and we call this one histamine H receptor antagonist. Okay, we can use prostaglandin. What type of prostaglandin? Agonist or antagonist? Okay, I will leave it for you to tell me that. About muscarinic, we need to inhibit muscarinic in order to decrease release. We can use some muscarinic receptor antagonist. Okay, then prostaglandin, what do you think here? Stimulate or inhibit? We need to stimulate. We call this one analog. Okay, analog means stimulate prostaglandin, or use something to inhibit gastrin. Okay, this number one. Also, they said we can use something to inhibit proton, and we call this one proton pump inhibitor. We have other approaches. We are going to discuss it later on. So here from this slide, we need you to remember what type of receptor do you have? Number one, what is the effect of this receptor? If you activate this receptor, what happened? What type of pathway, what type of second messenger will be involved in this effect? Okay, so you can see here how many groups. Number one, we can use something to block acetylcholine. And here we have suggestion, biranzapine. This is medication, block M3 receptor, biranzapine. So biranzapine, anti-muscarinic medication, block M3 receptor, decrease acid secretion, number one. Number two, we can block histamine receptor, H2 receptor blockers. And you can see the minus here, that means block. So we have famotidine, Pepsid, or Pepsid. So famotidine block H2 receptor, block histamine receptor. This is another group of medication. We can use H2 blocker. And they said for the prostaglandin, we can use analog of prostaglandin, something mimic the effect of prostaglandin. We have misoprostol. Misoprostol stimulate prostaglandin release. We don't have any medication affect the gastrin because the situation here is not applicable in the clinical practice. We don't have any medication currently affect the gastrin or gastrin receptor in the blood. Okay, they said another option there, we can block the proton pump or the enzyme called, or the pump. So the pump could be blocked by something called proton pump inhibitors. So we have list of medication able to block the proton, and we call this one proton pump inhibitor. Give me a name for that, omeprazole. So we can see here now we have how many medication? We have several medication. Biranzapine, M3 antagonist. Famotidine, H2 blocker. Misoprostol, prostaglandin analog. Omeprazole, proton pump inhibitor. They said that's fine. So now we have number one, M3, number two, H2 blocker, number three, prostaglandin analog, number four, we have proton pump inhibitor. Then number five, before we go to number five, they found later on, you can see here we have Helicobacter pylori. And this is one of the most common causes of peptic ulcer disease. So our target will be, in this case here, when you do the endoscopy and we take the biopsy, and the biopsy confirm Helicobacter pylori. So what we are going to do here, we are going to prescribe some combination therapy, could be triple therapy or quadruple therapy, to eradicate Helicobacter pylori. So we call this one Helicobacter pylori eradications. So 1, 2, 3, 4 here, and 5. This is maybe number 5 approach for the situation. Try to eradicate Helicobacter pylori. Other approach, okay, we have acid in the stomach, and you can see we have acid. What about using antacid? They said antacid could be target number. This is number 6. Okay, antacid could be maybe possible. Okay, possible approach, antacid, to neutralize the acid in the GI stomach. And the last step will be using the mucosal protective agent. And you can see here we have the ulcer here. If we use a green one, let me use a green one here, and we have ulcer, and this is the ulcer here. Okay, and we use some mucosal protective agent, and this protective agent try to cover the ulcer. So for example, when you have wounds on your hand, you put bandage on your hand, try to cover the ulcer, try to cover the wound or any ulcer in your skin. But we cannot maybe place bandage in our stomach. Therefore, we can use some medication able to protect the mucosa. So we have some protective factors, mucosal protective factors, and this will be number 7. So you can see here from this graph, I will clean all these, and then we try to maybe put the number for the medication used for peptic ulcer disease to make it like easy for us, and maybe. So you can see here what we have, maybe list of medication used. Number 1, we can use muscarinic antagonist, H2 blocker, prostaglandin analog, proton pump inhibitor, eradicate Helicobacter pylori, antacid, or last one, mucosal protective agent. So you can see here we have 7 group in the practice, in the clinical practice. Someone maybe argue about gastrin. It's not, to my knowledge, we don't have medication affect the gastrin in the practice. Okay. Okay, we have practice question here, and the question: which of the following is or are capable to inhibit gastric acid secretion? Select all that apply. So we're looking for agent or mediator, or like local mediator, or like hormones or anything inhibit gastric acid. So which of the following agent inhibit gastric acid? Which of the following inhibit gastric acid? So I will start with the first one, and yes or no. Acetylcholine inhibit gastric acid, yes or no? If you said no, you are correct. Histamine, no. Gastrin, inhibit gastric acid, gastrin, no. Somatostatin, if you said yes, you are correct. NSAID. What about stress? What about Helicobacter pylori? Prostaglandin inhibit gastric acid? Correct. Okay, so anything inhibit gastric acid in this list, we have somatostatin inhibit and prostaglandin inhibit. So acetylcholine, histamine, gastrin, NSAID. So the correct answer will be, according to this one here, somatostatin and prostaglandin. Okay, another maybe case, or like fill in the blank. They said acetylcholine or acetylcholine acting on the M3 receptor. What happened there? Acting on the M3 receptor, the blank pathway resulting in increased proton pump inhibitor. So do you think M3 receptor stimulate the cyclic AMP, stimulate the calcium, or inhibit calcium, or inhibit cyclic AMP? So which one will be involved in the acetylcholine acting through M3 receptor? Stimulate what? Stimulate cyclic M3 receptor, stimulate cyclic AMP, stimulate calcium, inhibit calcium, or inhibit cyclic AMP. This will lead to take you to the previous slide, only to show you what we have. Okay, this is acetylcholine here, bind to the M3 receptor, activate GQ protein, increase calcium, you see it here, and this will lead to the activate protein kinase here. If you go back, we have protein kinase, activate protein kinase. So if you go to the slide, okay, which one here will be, okay, what do you think? Stimulate calcium dependent. So acetylcholine binding to the M3 receptor, this will lead to the stimulation of calcium dependent and activates acid secretion. Okay, so moving to the discussion of the desired outcome of treatment. Overall, the treatment aimed to relieve ulcer pain. We need to relieve pain, enhance healing ulcer. So pain, number one, we need to release the pain, relieve the pain, decrease the pain. Healing the ulcer, we try to heal the ulcer. Prevent recurrence of ulcer. So number one, relieve pain, healing the ulcer, prevent relapsing or recurrence, and reduce complications. So this is a goal of therapy, aim of therapy: pain, heal the ulcer, prevent recurrence, and reduce complications. And they said we have two main therapeutic goals. Number one, to heal the ulcer, as you can see here. We need to heal the ulcer, and if you have infections or like bacterial, we need to eradicate the Helicobacter pylori. Okay, the patient, we have some patients come to the clinic with suffering from peptic ulcer disease, or they are at risk of peptic ulcer disease, developing of peptic ulcer disease, and they are on NSAID. So they consider like high risk of developing peptic ulcer disease. Those patients should receive prophylactic co-therapy. So we can, for example, for this patient, we can switch the patient from NSAID to the COX-2 inhibitor, for example. So here the purpose of this, maybe convert the patient from NSAID to the COX-2 inhibitor to reduce risk of peptic ulcer disease and related complications. So we have now the rationale. If the patient come to the clinic suffer from peptic ulcer disease related to the NSAID, we can stop NSAID and switch the patient to the COX-2 inhibitor to reduce risk of peptic ulcer disease or complication of peptic ulcer disease. Of course, we have another approach here. We can, if the patient in need to take NSAID, we can prescribe like H2 blocker, H2 receptor blocker, or we can prescribe proton pump inhibitor with the NSAID to protect the GI system. So we have two main approach. We discussed that in the antiplatelet. We discussed that with the arachidonic acid and prostaglandin. Okay. So what we have here, as you can see, the patient is on NSAID and come to the clinic suffer from peptic ulcer disease because we inhibit COX-2, and COX-2 responsible for gastroprotection. So if you inhibit COX-2, this will lead to the decreased gastric protection, and this will lead to the imbalance between defensive factor and aggressive factor. You remember that. So we have decrease of cyclooxygenase, decreased gastroprotection, okay, because we need prostaglandin, okay, and COX-1 responsible for formation of prostaglandin, and we need the prostaglandin. When you prescribe NSAID, okay, when you prescribe NSAID to your patient, whoops, okay, when you prescribe NSAID to your patient, okay, prescribing NSAID, this will lead to the inhibit prostaglandin, lead to the decreased gastroprotection. Okay, and someone will maybe argue what you mean with the protection. What is the role of prostaglandin? If you remember, prostaglandin, they found prostaglandin role in the GI system. Prostaglandin increased release of mucus. Okay, prostaglandin increase blood flow. Prostaglandin increase release of bicarbonate. So you can see here that all these like considered like defensive factor if you go back to the balance between aggressive and defensive factors. So the option here we have to protect a patient from peptic ulcer. We can switch the patient from a traditional standard NSAID to another group of medication called celecoxib, or could be COX-2 and selective COX-2 selective inhibitor. So if you move the patient to the COX-2 selective inhibitor such as celecoxib, this one will only inhibit COX-2 and avoid the COX-1 and leave the effect on the beneficial effect on the GI system. Okay, now we have the case here. 61-year-old patient suffer from joint pain due to his chronic arthritis disease. He has been admitted to the hospital 6 months ago because of his severe abdominal pain, and he has been diagnosed with the peptic ulcer disease. Which of the following treatment is or are best treatment for joint pain in this patient? Select all that apply. Okay, I will move to the next. So here the case, the patient suffer from chronic arthritis, peptic ulcer disease. Okay, so which medication we are going to use for this patient? Ibuprofen, meloxicam, celecoxib, Tylenol, aspirin. I will start with the aspirin. Aspirin causes 4+ in gastric irritation. We don't prefer to use aspirin in patients with peptic ulcer disease. We don't prefer to use it because gastric irritation. Ibuprofen, 2+ for gastric irritation. We don't prefer to use it. Okay, Tylenol. Can someone tell me what happened here? Can we use Tylenol for chronic arthritis? So Tylenol is not okay anti-inflammatory medication. Is not. So if the patients are from chronic arthritis, this is not good option. So what we have here, we have celecoxib. Celecoxib considered like COX-2 selective inhibitor, and they said we have meloxicam could be prescribed. Okay, the correct answer here, we need to avoid the peptic ulcer, maybe aggravate symptoms, meloxicam and celecoxib. Okay, we're done with the maybe a brief introduction to the physiology, pathophysiology, signs, symptom, causes. Now we start with the management of peptic ulcer. Management of peptic ulcer disease. We have non-pharmacological approach treatment and we have pharmacological approach treatment. For non-pharmacological approach treatment, we recommend patient to eliminate or reduce stress. We recommend patient to eliminate and reduce or stop smoking, cigarette smoking. We recommend patient to stop using NSAID, especially the non-selective and aspirin. Okay, we recommend patient to avoid spicy food and caffeine, a lot of caffeine and alcohol. We recommend patient to replace NSAID, for example, with acetaminophen or other COX such as celecoxib. Okay, so could be acetaminophen, celecoxib, depends on the case. Some patient, if they suffer from complication of peptic ulcer disease such as bleeding, obstruction, or perforation, we have some elective surgery could be performed for this emergency case. Emergency cases here. Okay, so we need surgery for this case. Okay, so stress, alcohol, caffeine, spicy food, cigarette smoking, okay. Pharmacological treatment, how we can treat the patients. Here we have groups of medication could be used to treat peptic ulcer disease. We have suppression acid secretion. Okay, which medication decrease secretion of acid? Medication decrease secretion of acid. Medication suppress the acid secretion. Number 1, proton pump inhibitor, like 80 to 90% of 95% of acid will be inhibited. Histamine, 70% of the acid will be inhibited, histamine blocker. So number one, proton pump inhibitor, PPIs. Number two, histamine H2 blocker receptor. Number three, muscarinic receptor antagonist. So we have three main group of medication in decrease secretion of acid. Proton pump inhibitor, H2 blocker, histamine H2 blocker, muscarinic receptor antagonist. That's great. Okay, we have the acid in the stomach. So we can use something called neutralization agent or neutralizing agent. Acid neutralization. You can use some acid neutralization agents such as antacid, Malox, for example. What about the mucosal protective agents? We can use sucralfate, bismuth, subsalicylate, prostaglandin analog, such as misoprostol. Okay, if the patient maybe undergoes a endoscopy and biopsy and they confirm infected by the Helicobacter pylori, we can go with the antibiotic, could be combined with the other medication to eradicate Helicobacter pylori. We have amoxicillin, clarithromycin, metronidazole, and tetracycline. So all these group of medication, and we can add some levofloxacin, for example, here. Okay, like this one belongs to the fluoroquinolone. Okay. So we start with the. So I will go back again to remind you. We have a group of medication here. You need to remember all these medication. For example, here, and this is important for us. We have four main groups. We use medication to decrease acid secretion, medication to neutralize the acid, medication to protect the stomach, and if we have bacterial, we use some antibiotic to eradicate the bacteria. So here we have the diagram for the treatment of peptic ulcer disease. Four main group: decrease secretion, neutralize acid, mucosal protection, eradicate Helicobacter. So which medication belong to the acid suppression? So we have proton pump, H2 blocker, muscarinic antagonist. Which of these medication neutralize the acid? We have antacid. Which of these medication eradicate the Helicobacter pylori? We have antibiotic, amoxicillin, clarithromycin, metronidazole, and tetracycline. Okay, first group of medication, as you can see here, we have H2 receptor blocker, H2 receptor antagonist. We have several medications: cimetidine, tagamet, famotidine, nazatidine, ranitidine, and we have the brand name Pepcid, Tagamet, Zantac, and so on. And if you are interested, you can, most of these medication, for example, this is available OTC, no prescription needed, available tablet, chewable tablet, suspension, injection, and we have some warning from the FDA about the ranitidine may cause associated with cancer. Here we withdraw from the US market. So four medication belong to the H2 receptor, histamine H2 receptor blockers. We have cimetidine, tagamet, famotidine, Pepcid, nazatidine, Exed, and we have ranitidine, Zantac. And we have the medication like capsule, oral, whatever. So we have some medication here, for example, available tablet, capsule, suspension, syrup, and injection. Okay, how this medication work when we talk about histamine, H2 receptor antagonist, we can call this one histamine blocker, H2 blocker. This medication competitively block the histamine receptor. Okay, this medication competitively mean irreversibly block the histamine blocker. Cimetidine prototype, first medication in the group, prototype, cimetidine, a prototype of histamine receptor, the first medication in the group. Okay, the histamine H2 blocker effectively inhibit basal acid secretion, and we know that basal acid secretion produced during sleeping or during at night. Therefore, this is considered like most effective agent if you take it before sleep or at night, because we have the basic acid secretion. Uses: we use a H2 blocker, histamine H2 blocker, cimetidine, ranitidine, nazatidine, famotidine. We use this medication for patients from peptic ulcer disease, gastric ulcer, for duodenal ulcer, for stress ulcer. If you speak about acute, that means we are going to use it in emergency room, emergency department. And in this case, we are going to prescribe it intravenous. For example, intravenous, we have, for example, here famotidine. Okay. we can use this group of medication for patients who suffer from gastroesophageal reflux, GERD. So, peptic ulcer disease, acute stress ulcer, GERD. Pharmacokinetic, this medication start maybe effect within 60 minutes. Duration maybe remain in the effect for 4 to 10 hours duration of action. This group of medications suppress 70% of acid secretion, gastric acid, 70%. So H2 blockers inhibit 70% of gastric acid, but they said PPI suppress 80 to 95% of acid. So which one most effective, PPI or H2 blocker? PPI most effective because suppress 80 to 95% of acid. H2 70% of acid. Okay, this is number one. Number two, from this maybe slide, we can see here the drug name, cimetidine, ranitidine, nizatidine, famotidine, and we have the brand name. Then they start talking about potency. Okay, so if you speak about cimetidine, potency 1. So when you use one tablet, for example, cimetidine, potency 1. Ranitidine, 4 to 10 times more potent than cimetidine. Nizatidine, 4 to 10 times more potent than cimetidine. This is nizatidine. Famotidine considered like 20 to 40 times more potent than cimetidine. So from this slide here, we can ask question. Which of the following H2 blocker considered like the most potent H2 blocker? I will repeat the question. Which of the following H2 blockers considered like the most potent medication to block the acid secretion? If you answer 4, famotidine, Pepsid, well, you are correct. The most potent, 20 to 40 times most potent than cimetidine. Okay, you can see the potency here. Famotidine the most potent, and the least will be cimetidine. And we have the doses here for the medication: famotidine, nizatidine, ranitidine, and cimetidine. So we talk about potency. Again, if you go back, we already explained that with you, discuss it with you. We can see here with the regarding the potency, equivalent dose and potency. So 20 milligram of famotidine is equivalent to the 400 milligram cimetidine to produce the same effect. So the most effective medication will be famotidine. The least will be cimetidine. So the question, which of the following considered like the least effective medication, the least potent medication, cimetidine. The most effective medication or the most potent medication will be famotidine. Okay. Okay, so we done with speaking about H2 blocker, and we discussed the mechanism of action, we discussed the clinical use, and we discussed the potency of H2 blocker, histamine 2 receptor antagonist. We have some side effect we need to discuss with you. Number one, they said this medication may cause this medication may cause headache, dizziness, diarrhea, muscle pain, or muscular pain, and constipation, and less than 3% of patients may suffer from this side effect. Cimetidine, on the other hand, also they found cimetidine inhibit binding dihydrotestosterone, DHT stand for dihydrotestosterone, inhibit binding dihydrotestosterone to the androgen receptor, and this will lead to the inhibition of metabolism of estradiol and increased level of prolactin. So cimetidine increased level of prolactin. Cimetidine will be inhibit metabolism of estradiol, and cimetidine will be bind to the inhibit binding dihydrotestosterone to the androgen receptor. We call this one anti-androgenic receptor. Okay, for this reason, cimetidine cause gynecomastia, cause impotence, and galactorrhea. So talking about gynecomastia and impotence in men and galactorrhea in women. What else was they said? Also, cimetidine inhibits several cytochrome B450. You can see here in the graph, cimetidine inhibits several cytochrome B450. This is cytochrome involved in metabolism and several medications such as warfarin, diazepam, phenytoin, quinidine, carbamazepine, thiophanate, imipramine. This medication should be metabolized in the liver, but our medication, cimetidine here, inhibit cytochrome B450 and prevent metabolism. So what happened to these medication in the blood? Increase blood concentration. So this medication will be increased in the blood. So I will go back to the text. Cimetidine inhibits several cytochrome metabolism, and this slow progression, slow metabolism, and potentiate the action, increase serum concentration of this medication. So we can discuss with you one of them, for example, me and you together. Okay, if the patient come to the clinic and he is in warfarin, and we know that warfarin used for the deep vein thrombosis, for example, or the VTE, deep vein thrombosis of venous thromboembolism, we prescribe warfarin, and this patient suffers from abdominal pain, and you decide to prescribe cimetidine. What happened here? So the situation will be cimetidine. When you prescribe cimetidine, the cimetidine will inhibit cytochrome B450, and this will lead to the increased level of warfarin in the blood, increased level of warfarin in the blood. Okay, increased level, and this will lead to the risk of bleeding. The bleeding could be minor, could be major, so we have different approach depending on the situation. But you can see here from drug-drug interaction, cimetidine is not allowed, it's not recommended to use it with a patient take warfarin. And now we understand why we don't use it with the patient take warfarin. Or patients suffer from epilepsy, for example. And this patient already on carbamazepine, and you can see it here, carbamazepine, and we don't recommend to use cimetidine for this patient. So you can see here we have different approach for the patient, different case study, and this explains why cimetidine is not recommended to use with this medication. Okay, please remember the drug-drug interaction carry with the cimetidine. Okay, you can see here the cimetidine may cause gynecomastia, gonorrhea, and impotence, and happened with when we have high dose of cimetidine, and this is related to the anti-androgenic effect and increased level of prolactin. It's already covered in the slide here. You can see it. We already cover all this information here for the cimetidine, and we have it in another slide like diagram. Okay, so related to the effect. What happened with the other medication is the same, apply for H2 blockers. So cimetidine carry a lot of side effect. What happened to the ranitidine, famotidine, nazatidine? Ranitidine, they said the ranitidine is longer acting, okay, more potent than cimetidine, minimal side effect. That's great. So we have ranitidine, longer acting, more potent, minimal side effect. Okay, that's great, and does not produce the anti-androgenic effect related to the prolactin. So all these like advantages of ranitidine. Number one, long acting. Number two, more potent. Number three, minimum side effect and less prolactin stimulated effect. Okay, moving to the talk about potency 5 to 10 times. They said, what about famotidine? Famotidine the most potent. Famotidine the most potent H2 blocker. Okay, and similar similar profile, safety profile, similar safety profile to ranitidine. Nazatidine similar to ranitidine also. How we can manage, how we can work with this patient here? They said cimetidine, ranitidine, famotidine. This three medication. I will repeat it. This three medication. Okay, this three medication. Okay, in contrast to these medications. These three medications metabolize in the liver. In contrast to cimetidine, which are metabolized in the liver. So cimetidine, ranitidine, famotidine metabolize in the liver. They said nazatidine metabolized in the kidney. Okay, and some study they said nazatidine had maybe carry the bioavailability 100%. Okay, which of these H2 blocker metabolized in the liver? We have cimetidine, ranitidine, famotidine. Which of these medication eliminated through the kidney mainly will be we have nazatidine. Okay, so in 2020, I think we have the update from the FDA regarding the risk of cancer. They said FDA is alerting patient and healthcare professionals to two voluntary recall related to ranitidine, and this one is related to the substance called NDMA substances, and this substance may increase risk of cancer, and they found this substance in ranitidine. Okay, NDMA stands for N-nitrose dimethylenamine. Okay, so we have the maybe clarification from the FDA or like update announcement related to the ranitidine may cause risk of cancer due to the availability of substance called NDMA. Okay, slide here to show you the clinical potency for the H2 blocker. That you can see potency 1, then we have 410, and famotidine, the most potent agent in this chart. Okay, now move to the case study. 55-year-old patient complaining from heartburn, abdominal pain. He has been on H2 antihistamine for 3 months, and he noticed that enlargement of his breast. His doctors changed his prescription to other H2 antihistamine does not involve in gynecomastia. Which one of the following H2 antihistamine does not cause gynecomastia? Okay, I will start with the number 1, omeprazole, yes or no? Famotidine, cimetidine, lansoprazole, metronidazole. Okay, let me start from the last one, E, metronidazole, yes or no? Metronidazole. No. What about metronidazole here? No. Omeprazole? No. Lansoprazole? No. Cimetidine? What do you think? Yes or no? Of course no. And the correct answer will be famotidine. What is omeprazole? PPI. Metronidazole? Antibacterial drugs. Lansoprazole, PPI. Cimetidine cause gynecomastia. So we need to select which of the following does not cause gynecomastia. So the correct answer will be famotidine. Okay. Moving to the next group of medication, we have proton pump inhibitor. Proton pump inhibitor, and another name will be hydrogen potassium ATPase inhibitors, proton pump inhibitors, or sodium hydrogen potassium inhibitors, hydrogen potassium ATPase inhibitors. Okay, speaking about this medication, the most efficacious acid inhibitory agent inhibit 80 to 90% of acid. If you speak about H2 blocker, inhibit 70% of acid. But talking about PPI, inhibit 80 to 95%. This medication is considered like inactive drugs, prodrugs. So this medication considered like prodrugs, inactive. This medication need to be activated in the acidic secretory canaliculi and of the parietal cells. Okay. So if you speak about the okay, this is the parietal cells, and then we have the proton pump here, and we have the canaliculi here, and the proton pump inhibitor should arrive to this place, to the canaliculi. Proton pump inhibitor should arrive to this place here to inhibit the proton. Okay, and the pH here should be acidic. So the acidic pH in the canaliculi, inside the parietal cells, the pH will be acidic. The acidic will help to activate proton pump inhibitor. Activation proton pump inhibitor will inhibit the proton. So we need the acidic secretory in the canaliculi. Canaliculi. So what happened there with the acid? So when you prescribe proton pump, you can see it here. So when you prescribe the proton pump inhibitor, considered like prodrugs, this will convert or metabolize to sulfinamide, not sulfonamide, sulfinamide, and this sulfonamide irreversibly inhibit proton pump. So you can see here, if you go back to the H2 blockers, and remember that there what we have there reversible inhibit of H2 receptor. So H2 blocker reversible inhibit H2 blocker, but talking about proton pump irreversible inhibit this pump. Okay. Moving to the this medication bind, you can see proton pump bind to the proton pump inhibitor, PPI bind to the proton pump irreversibly and inhibit the final step of acid secretion. Okay. Okay, to prevent degradation of proton pump by the acid and the gastroclomin, oral dosage form are supplied in different formulations. So we need this medication to be activated near to the target, near to the proton pump. We don't need it to be activated in the stomach and the lumen. So for this reason, we have it in the enteric-coated or delayed release or powder like in capsule and powder combined with the sodium bicarbonate. So we have enteric-coated, delayed release or powder omeprazole. We need to prevent them from the degradation in the acid and the lumen. We need to be this medication to be activated in the acidic environment near to the target of the varietal cells. Okay. Talking about the pharmacokinetic, this medication, when you take this proton pump, this medication, for example, this medication moving from the oral to the esophagus, to the stomach, to the small intestine, the first part of the duodenum, then this medication will be absorbed. And when this medication will be absorbed, we have something called first pass metabolism. We'll go to the liver. Then we go back through the blood, and through the blood will come back again to affect the ulcer. So it's not local effect. It's not local effect. It's systemic effect. So we have systemic effect when you take the proton pump omeprazole orally. The omeprazole arrives to the stomach, then to the intestine, and from the intestine will be absorbed to the blood, to the liver. In the liver we have metabolism, then produce, maybe leave the liver to the blood and come back again to the target. So you can see here the process or the pathway for the metabolism for this medication, for omeprazole and lansoprazole and other medications here. So please remember the effect will be systemic effect, not local effect. Local effect when you speak about antacid. Antacid will be local effect. But for proton pump, H2 blocker, systemic effect. Okay, so this medication, when you take this medication, it's a plasma half-life 0.5 to 3 hours, duration of action 1 to 3 hours, and onset of action 1 to 3 hours, but the activity will remain 24 hours. I don't know how we can explain that. Can you explain it to me? What happened? Duration of action only, onset of action. When you take it, they start work in 1 to 3 hours. Okay, but the effect remain for 24 hours. The plasma half-life 1 to 3 hours. What happened there? That means plasma half-life only 3 hours. That means after 3 hours, 50% of the medication will be decreased from the blood. So if you talk about plasma half-life, in this case, when you have short half-life, half hour to 3 hours, that means we need to prescribe this medication several times per day to maybe reduce the effect. However, we don't maybe decide the frequency of medication depends on the plasma half-life. We decide this one on the duration of action. And if you go back to the previous slide, you can see this what we have there. The medications, the PPI, this medication irreversibly inhibit the proton pump, and our body need 24 hours to resynthesize a new pump. Okay, so our body need 24 hours to resynthesize a new proton pump. For this reason here, we prescribe the proton pump once per day or twice daily, depends on the severity. So this medication you prescribe once daily according to the mechanism of action, not according to the plasma half-life. Okay, the proton pump may cause talking about diarrhea. It may cause talking about adverse effect or side effect, may cause diarrhea, and may cause Clostridium difficile colitis, and this involved in something called pseudomembranous colitis. Decreased absorption of iron, calcium, B12, magnesium. For this reason here, we don't recommend to use a proton pump together with the ions or with the calcium or with the B12. So if the patients have from anemia, try to maybe make a distance between these two medications, at least like 4 to 6 or 7 hours, 8 hours. I prefer not to take this medication together, because when you take omeprazole with the ions or calcium or B12, this will lead to the decreased absorption of these medications. Study found that in rare cases we have some maybe osteoporosis and risk of hip fractures. Okay, now speaking about food, if you remember that omeprazole, lansoprazole, two medication only, Brolosec and Brevacid. These two medications should be taken before food, because food will be deactivate this medication. Food will be maybe affect this medication and decrease activity of this medication. So this medication should be taken before food, like 30 minutes before food. Okay, then what we have here, we have some other medication. They developed enteric-coated medication, for example, and there's no effect of food without regard to meals. Without regard to meals, we can take it on empty stomach. Okay, dexlansoprazole, pantoprazole, lansoprazole, we can take it without regard to the meals. So the question here, which of these medications can we take it without regard to the meals? Dexlansoprazole, pantoprazole, rabaprazole. Lansoprazole, omeprazole, esomeprazole, all these should be taken with 30 to 60 minutes away from the breakfast or the meal. Okay, so again, for the potency, also here we talk about potency, relative potency to measure. We have omeprazole potency 1, and I recommend you to compare with the H2 receptor blocker. If you remember, we have potency there, and the least to the which one is considered like highest? Least will be cimetidine, highest was famotidine. Okay, and the same will be applied here. Omeprazole considered like 1, and the least here will be pantoprazole, followed by lansoprazole, omeprazole number 1, esomeprazole 1.6, rabaprazole 1.8, the potency. So which one more potent? Rabaprazole, and followed by esomeprazole. Which one is considered like standard one? Omeprazole. Okay, therapeutic uses for the PPI. We use it for patients from gastric ulcer, duodenal ulcer, GERD, NSAID-induced ulceration, reflex esophagitis, or Zollinger-Ellison syndrome, which means tumor produce gastrin and cause hypersecretion of HCl. So our repeated PPI, gastric ulcer, duodenal ulcer, GERD, NSAID-induced ulceration, reflex esophagitis, Zollinger-Ellison syndrome. Proton pump. clinical use, therapeutic use. Drug interaction, very important one for drug interactions. As you can see here, most of this medication, and here especially talk about omeprazole, the most important medication, omeprazole. Omeprazole metabolized by cytochrome B450, 2C19, and 3A4. Okay, this will lead to a lot of drug-drug interaction. This reminds us with the same cimetidine. Cimetidine carried a similar results, drug-drug interaction. So omeprazole inhibit metabolism of warfarin, diazepam, phenytoin. Okay, so when you inhibit, that means the level of this medication will increase in the plasma. Inhibit metabolism. Phenytoin plasma increase, warfarin plasma increase, diazepam plasma increase, and we can look on the consequences. Okay, omeprazole. On the other hand, they said rabeprazole, pantoprazole have no significant drug interaction. So I prefer to go with the pantoprazole and rabeprazole because both of them have less or no significant drug interaction. Omeprazole maybe inhibit metabolism of several medication such as phenytoin, diazepam, and warfarin. Okay, on the other hand, they try to remind us acid is very important for absorption for some medication. We need acid to absorb medication. We need acid for absorption of ketoconazole. We need acid for absorption of itraconazole. We need acid to absorb digoxin. We need acid to absorb atazanafir, antivirus medication. Okay, so in this case, they found all PPIs decrease gastric acidity, and this will decrease absorption of such medications such as ketoconazole, atazanafir, digoxin, and itraconazole. So proton pump inhibitor decrease absorption due to the alteration of acid in the GI system. Okay, so the most important one in this slide here, the most important one, omeprazole. Omeprazole carries the risk of high drug interaction, the most important one, followed by esomeprazole. So omeprazole, esomeprazole, the most important medication, carry the risk of drug-drug interaction. Here we talk about 2C19 and the number one on the list, clopidogrel. What is clopidogrel? I will leave it for you to answer this one, and I will go back again to this question. Omeprazole, esomeprazole, and the question from the slide here, which of these PPI carry the risk of high drug-drug interaction? Please remember omeprazole followed by esomeprazole. Okay, so you can see here PPI, proton pump inhibitor, maybe we need acid to facilitate absorption of iron. We need acid to facilitate absorption of digoxin, ketoconazole, and our medication decrease absorption of this medication. Okay. For the 2C19, we are going to discuss that with you. I delivered that question, but I'm going to discuss that question with you. What is the consequences when you prescribe omeprazole with the clopidogrel to your patient together? What is the result? So here we are talking about drug-drug interaction. What is the consequences? Okay, now we have patient 77-year-old who had been diagnosed with the deep vein thrombosis and visited BA clinic, was prescribed warfarin as a part of the treatment. While attending the clinic, the patient starts a physician assistant student who was in the middle in her rotation. The patient asked the BA student about possible drug-drug interaction of warfarin and PPI. Which of the PPI medication could potentially increase the risk of bleeding? Ketoconazole, rabeprazole, fluconazole, pantoprazole, omeprazole, lansoprazole. Which of these medications increase the risk of bleeding if you combined with the warfarin? PPI and warfarin. Which of the PPI will be? So asking about which PPI. The question here, if you look on the question, very important. Which PPI? First we look on the PPI. Which one is PPI? Ketoconazole? No. Rabeprazole? Yes, PPI. Fluconazole? No. Pantoprazole? Yes. Omeprazole? Yes. And lansoprazole? Yes. Please don't confuse with the ketoconazole. Ketoconazole antifungal medication. Fluconazole antifungal. Okay, which PPI could potentially increase risk of bleeding? Now the second step. So we have this group here. We identify 3 medication belong to the PPI: ribaprazole, pantoprazole, omeprazole, and lansoprazole. 4 medication. Which of these 4 medications? Which of these 4 medication belong to the which of these 4 medication may interact with warfarin? Which one? So we have B, C, B, D, E, F. Which one will be involved? If you answer it, omeprazole. If you combine omeprazole with warfarin, there is a risk of bleeding, because omeprazole inhibit metabolism of warfarin. Okay. Now moving to the clopidogrel and PPIs. So you can see clopidogrel considered like prodrug and need to be activated by cytochrome 2C19. Okay, that's fine. If you prescribe clopidogrel with omeprazole, esomeprazole, these 2 medication, if you remember, inhibit 2C19. Okay, and if you inhibit 2C19, you are going to prevent conversion of clopidogrel to the active form. If patient take clopidogrel and PPI, this increased risk of cardiovascular event. Agent with the minimum TC9, pantoprazole, lansoprazole, preferred to prescribe to the patient take warfarin or clopidogrel. So patient on clopidogrel, we prefer to go the pantoprazole or rabeprazole. And we have it on the slide. So please remember, clopidogrel inactive need to be activated by 2C19. Okay, this slide here. Clopidogrel inactive medication need to be activated by 2C19 to convert to the active metabolite, and clopidogrel anti-platelet medication. Okay, if the patient starts suffering from peptic ulcer disease and the physician prescribe omeprazole or esomeprazole, they found that omeprazole, esomeprazole inhibit 2C19, inhibit 2C19. That means this will prevent metabolism of clopidogrel. Okay, that means we have decreased effect of clopidogrel, and there is a increase of bleeding. What do you think? Increased risk of bleeding or increased risk of clotting? Which one? Correct. So when we have decreased metabolism of clopidogrel, there is increased risk of bleeding or clotting. Okay, the correct answer will be increased risk of clotting. Okay, which of the following PPI would be recommended to prescribe to the patient with a history of angina and this medication on clopidogrel? Omeprazole, esomeprazole, pantoprazole, lansoprazole, ketoconazole. What do you think? Which of the following PPI drugs? Ketoconazole. What do you think? Is the ketoconazole PPI drugs? Antifungal drugs. Okay, so we have brazole, brazole. Which of these brazole will be preferred? Pantoprazole. Pantoprazole preferred agent for the clopidogrel treatment. Here, I like what we have here with the highlight. They try to remind us with this medication, with the H2 blocker, you can see it here. Cimetidine. Okay, if the patients are from renal impairment or hepatic impairment, we need to adjust the dose. Cimetidine, Tagamet, and we don't use it in clinical. Cimetidine not popular in clinical use. Not popular in clinical use, cimetidine, due to the anti-androgenic effect, impotence, gynecomastia, not popular. But anyway, if you are going to use it, we need to adjust the dose if the patients are from renal or hepatic. Okay, this number one, cimetidine. Okay, what about other medication here? So three medication, famotidine, nazatidine, and ranitidine. They said if the patient suffers from renal impairment, please adjust the dose. So adjustment the dose required for the patient suffering from renal impairment for H2 blocker. Okay, moving to the proton pump inhibitors. Here we have a group of medication, as you can see it here. Okay, and what we have here, if you can look on what we have hepatic. Okay, so need to adjust the dose. So if the patients are from hepatic disease, those should be adjusted. Okay, which one considered safe in pregnancy? So B, category B, that's safe in pregnancy. We have one medication considered like teratogenic or like considered not teratogenic. To consider X in pregnancy, this is misoprostol and the brand name Cytotic. And this one not belong to the proton pump, this belong to the prostaglandin, and we are going to discuss that with you later on. So the highlight circle that mean important for us. Okay, so we're done with the group of medication. I think we discussed with you the H2 blocker, H2 receptor blocker. We discussed with you PPIs. Now we move to the antacid. Okay, number 3. This is number 1, 2, and this is number 3. So we move to the antacid here. Okay, so for antacid mechanism of action, antacid consider like weak base. Weak base react with the gastric acid and form salt and water and decrease gastric acidity. So neutralize. This medication neutralize the acid. This medication does not decrease secretion. This medication neutralize the acid, and we have it in the beginning if you remember. Antacid non-prescription medication, that means available OTC, no prescription needed. For heartburn and dyspepsia, we have common use, we have aluminum hydroxide, we have magnesium hydroxide, we have calcium carbonate, we have sodium bicarbonate. We have the brand name here, Alka-Zartar and Tums. We have milk of magnesia, and this one for like single medication, aluminum, magnesium, calcium, sodium. This medication, when you take this medication, they start working within minutes. So immediate effect. When you have abdominal pain due to the secretion of acid, okay, antacid start with a minute and remain for 30 to 60 minutes duration of action. So if you have any pain in the stomach due to the acid secretion, antacid will relieve the pain directly with the minutes. And then in the market we have some combination treatment between calcium and magnesium, and then we have magnesium and aluminum, Melox for example, Gaviscon. This is another combination work for treatment, magnesium aluminum with the Simeticone, Mylanta Classic, and we have, so you can see the medication here, aluminum, magnesium, calcium, sodium, aluminum, magnesium, calcium, sodium, aluminum hydroxide, magnesium hydroxide, calcium carbonate, sodium carbonate, and this medication start directly in minutes. Okay. Okay. So speaking a little bit for every individual medications, sodium bicarbonate, this medication, antacid, work locally but sometimes absorbed to the systemic circulation. Okay, absorbed to the systemic circulation, and sodium may increase blood pressure. So for this reason here they said there is a potential of metabolic alkalosis because we have the bicarbonate Alka-Zartars here absorbable. When you take this medication, sodium bicarbonate, this medication may absorb to the blood and may increase risk of hypertension. This medication may cause fluid retention and metabolic alkalosis. So which one of these antacid may absorb to the blood and cause increased risk of hypertension? Sodium bicarbonate. Which of these medication may cause metabolic alkalosis? Sodium bicarbonate. Moving to the calcium carbonate, Tums, may cause belching and metabolic alkalosis because we have carbonate. risk of alkalosis. Excessive dose of calcium carbonate may produce or lead to the hypercalcemia, increased level of calcium in the blood, hypercalcemia. We need to maybe differentiate between kalemia, thalassemia. So hyperkalemia, hypercalcemia, hypernatremia, all these we need to differentiate. When you say hypernatremia, we talk about sodium, hyperkalemia, potassium, hypercalcemia, calcium. Okay, magnesium hydroxide and or aluminum hydroxide. They said magnesium hydroxide, magnesium salt associated with diarrhea. When you prescribe magnesium to your patient may suffer from diarrhea. If you prescribe aluminum alone to the patient may suffer from constipation. For this reason here, because magnesium causes diarrhea, aluminum causes constipation, for this reason here we have like combination treatment together. Okay, these agents are commonly administered together, combination treatment between magnesium and aluminum, Melox for example, Melenta. So if you go back there, I will show you what we have. We have it together, aluminum and magnesium together. Okay, magnesium and together with the simeticone. Okay, all antacid reduce absorption of other medication. We need acid for absorption. We need acid for absorption of iron. We need acid for absorption of itraconazole, tetracycline, fluoroquinolones. What we are going to do here? So if the patient suffers from peptic ulcer disease, you prescribe antacid, and the patient take iron for anemia. What is your recommendation here? They said take this medication within 2 hours. Antacid should not be prescribed within 2 hours of this medication. So for example, if I take ions, I have to wait 2 hours, waiting time, then I will take antacid. So this is the waiting time to prevent interact with the absorption, because we need acid for absorption of iron, we need acid for absorption of tetracycline. Okay, moving to the case study here, we have 55-year-old women, maybe treated, have been treated for heartburn and with a self-medication. This medication includes magnesium hydroxide and aluminum hydroxide. What is the primary rationale behind the inclusion of both antacid in many commercial available products? So when we have it together, aluminum, what is the rationale for using magnesium and aluminum together? Okay, number one, to achieve bacterial effect. No. To prevent toxicity from antacid. No. Okay, to prevent a drug interaction. To enhance gastric empty. Okay, to reduce occurrence of the constipation and diarrhea. This is correct. So the correct answer will be E. Okay. So what we have here, I will maybe summarize what we have discussed already. We have H2 receptor blockers. We discussed that with you. Then we have proton pump inhibitors. And then we have antacid. And 1, 2, 3, number 4 now, we have mucosal protective agent. Mucosal protective agent. Okay, so we have 3 medication considered like mucosal protective agent. We have misoprostol, sucralfate, bismuth salts. And this medication, group of medication, enhance mucosal protection by several mechanisms. And this will lead to prevent mucosal injury, reduce inflammation, and healing existing ulcers. So all these, when you protect, when you cover the ulcer, when you have ulcer here we have the ulcer. Okay, when you cover the ulcer with this agent, and this will accelerate healing, reduce inflammation, and prevent from injury. So misoprostol, sucralfate, bismuth salt. So we have 3 medications considered like protective, mucosal protective agents. Okay, prostaglandin analogs. Here we have misoprostol, cytotec, considered like prostaglandin E1, inhibit gastric acid, stimulate mucus bicarbonate, enhance blood flow. So carbonate increase, mucus increase, blood flow increase, enhance, and inhibit gastric acid. If you go to the slide in the beginning, talking about the parietal cells, and you remember we have prostaglandin receptor, and this will affect GI protein, and this will decrease cyclic AMP and inhibit protein kinase, and this will inhibit the proton pump. So you can see the process for how this medication, if you go back, I refer you to the image, we have it in the beginning or picture. Prostaglandin, it's approved for the NSAID-induced ulcers. So if the patient take NSAID cause ulcer, so the drug of choice will be misoprostol, but it's not popular in clinical use because of the adverse effect, and it needs multiple dosing per day. What is adverse effect? Talking about adverse effect warning, precautions. This medication may cause abortion, uterine contraction during pregnancy. This medication may cause abortion. Misoprostol, we don't recommend to use in pregnant women. This medication may cause diarrhea and nausea. So we don't recommend to use misoprostol as a treatment or like traditional treatment for peptic ulcer disease. It's not popular in peptic ulcer disease. Misoprostol not popular due to the risk of abortion, due to the risk of abdominal pain, diarrhea, and nausea. Okay. So I create this slide, this diagram here, and you can, this diagram here, try to focus on the organ system or something. So we have arachidonic acid, if you remember. We have platelet, then we have mucosa, gastric mucosa, we have joint, we have endothelial cells. The purpose of this slide here to focus on two things. What type of enzyme we have in the GI system, COX-1, and this COX-1 responsible for gastric protection. And we already discussed misoprostol as a prostaglandin analog, okay, to protect the stomach, but we don't recommend it in the clinical use due to the side effect or abortion risk. Regarding the joints, we have enzyme called COX-2. COX-2, this enzyme responsible for prostaglandin, and they found prostaglandin in the joint responsible for pain, fever, inflammation. Okay, so we focus on two things here for us, but we need to discuss here also what happened in the endothelial cells and platelets. So you can see here in the platelet we have COX-1, in the endothelial cells we have COX-2. So if you talk about platelet COX-1, the enzyme available in the platelet responsible for formation of prostaglandin, and this prostaglandin called thromboxane A2. If you stimulate thromboxane A2, increase formation of thromboxane A2, the result will be increased platelet aggregation and vasoconstriction. Platelet aggregation and vasoconstriction, that means there is a risk of glutting, and there is a risk of maybe vasoconstriction. Okay. On the other hand, we have another enzyme called COX-2 responsible for formation of prostacyclin. If you enhance prostacyclin formation, the result will be decreased platelet aggregation. That's great, good news, and cause vasodilation. So you can imagine now we have balance. We have balance between we have arachidonic acid, then we have COX-2, and we have COX-1. COX-2 responsible for thromboxane A2, and COX-2 responsible for prostacyclin. And we have balance between two factors here to protect from the platelet aggregation glutting. Okay, so you can see here if the patients suffer from peptic ulcer disease, plus arthritis, okay, the drug of choice will be celecoxib to avoid inhibitory pathway of COX-1. We need COX-1 to remain benign. We need it to remain function, because COX-1 responsible for prostaglandin. That's great. If you prescribe NSAID to your patient, such as ibuprofen block both COX-1, COX-2, and this will lead to the irritation and decrease the prostaglandin, inhibit enzyme, decrease prostaglandin, and may cause ulcer. Okay, for this reason they said, okay, what happened here? Can we prescribe, for example, ibuprofen with misoprostol to protect the stomach? They said yes, but you remember we discussed the side effect of misoprostol. Okay, so we're done with the prostaglandin analog, and we discussed what happened there with this diagram, with this chart, with this image. Move to the second medication that considered like a protective mucosal protective agent, sucralfate. Sucralfate is the salt saccharose complex to sulfate aluminum hydroxide, and if you remember, aluminum involved in constipation. Aluminum may cause constipation. This medication need to work in the acidic environment, so we need acid to be active. Sucralfate need to work in the acidic environment. Therefore, we don't use sucralfate with antacid. We don't use it because if you use antacid with sucralfate, this will inactivate sucralfate. So you can see here we need acid for sucralfate to work. If you use it with the antacid, this will lead to inactivate of sucralfate. Okay, so for this reason we don't use it together. We don't have it in the market together. Sucralfate should not be administered with a PPI, H2 blocker, or antacid. Yes, because if you use it with these medication together, this will lead to inactivate. If you use it, this will lead to the inactivate of sucralfate. So we don't recommend to use it together. This medication covers the ulcer and cause physical barrier, prevent from the ulcer from the acid exposure, and enhance healing of the ulcer. This medication also may cause hypophosphatemia by competition with the phosphate in the body. Okay, two main side effects, constipation and hypophosphatemia. The last mucosal protective agent, the last one here, will be bismuth substrate, Pepto-Bismol. Bismuth substrate available in combination with the prescription with the metronidazole, tetracycline. Bismuth, they found bismuth substrate stimulate prostaglandin mucus bicarbonate and direct antimicrobial effect on H. pylori. Okay, and we have substrate and then we have subsalicylate. So we have two types of bismuth. Bismuth substrate could be used with a tetracycline and metronidazole to treat H. pylori. And mechanism of action, this medication stimulate prostaglandin mucus bicarbonate secretion. Okay, so, bismuth subsalicylate, if you go to what we have here, subsalicylate, they said this medication has antibacterial effect, inhibitory effect of due to salicylate, inhibitory effect on the prostaglandin and the chloride secretion. So we need you to remember subsalicylate. Salicylate belong to similar to the aspirin. So subsalicylate mean anti-inflammatory effect, and bismuth have infectious use like effectively in infectious diarrhea. Bismuth available like non-prescription, coobictate and Pepto-Bismol, used for patients from acute diarrhea, non-specific acute diarrhea. So we can see here infectious diarrhea, acute diarrhea, and traveler diarrhea. So three types of diarrhea could be used with the bismuth subsalicylate: infectious diarrhea, okay, acute diarrhea, non-specific treatment of acute diarrhea, and traveler diarrhea. Okay, side effect, yes, bismuth cause blackening of stool, and this one will confuse the patient with the bleeding. Is the patient bleeding from that? Darkening the tongue, okay, and should be avoided in patients with renal insufficiency. And they found if you use bismuth for a long time, this will lead to the encephalopathy. Patients may suffer from headache, seizure, and confusion. High dose of bismuth may lead to the salicylate toxicity. Okay, all these should be considered. Effect on the stool, darkening the tongues, renal insufficiency, risk of encephalopathy, risk of salicylate toxicity, all these associated with the using of bismuth subsalicylate and bismuth substrate. Okay, we have case here. We have 34-year-old woman visit the primary care for heartburn. Okay, she reported that discomfort when she consumed spicy food, and this worsening when she lies down to sleep. She did not experience any dysphagia or weight loss or grade of fever or anything or blood in the upon examination. No abnormality are observed. You inform her that she likely has the gastroesophageal reflux disease, GERD, and you discuss with her the pharmacological treatment, okay, including over-the-counter drug that act as weak acid. What do you think? Weak bases, not weak acid, sorry. So you can see here we discuss the possibility of prescription weak base that decrease acidity. Which of the following drug can neutralize stomach acid through the localized action? So we have two things. We're looking for medication to neutralize acid through the local effect. I will start. Tetracycline, yes or no? If you said no, you are correct. Sodium bicarbonate, neutralize local effect. Yes. Ranitidine, yes or no? No. Misoprostol. No. Metronidazole. Magnesium hydroxide. Yes. Is omeprazole. No. Clarithromycin. Antibiotic. Calcium carbonate. Yes. Amoxicillin. No. Aluminum hydroxide. Okay. What do you think this one we call this one antacid. Okay, antacid. Okay. Following surgery to remove colon polyp, as 76-year-old woman reported experience epigastric pain. After procedure, her overall health quickly declined. Her health declined quickly, leading to the transfer to the intensive care unit. And which of the following treatment approach suitable to prevent peptic ulcer, to prevent stress ulcer related to mucosal bleeding? So we have stress ulcer and bleeding. This is emergency department treatment. ER. Okay, which of the following treatment will be appropriate for this patient? Metoclopramide, ondansetron, sucralfate, bismuth, famotidine IV. Metoclopramide, this medication used for vomiting and nausea. It's not this medication. Ondansetron, vomiting and nausea. It's not for this medication. Sucralfate, this is like protective, mucosa protective agent. Bismuth subsalicylate, diarrhea and H. pylori, increase maybe mucus by prostaglandin. No, the correct answer will be famotidine IV infusion to treat peptic ulcer disease. Okay, we move to the maybe last group in the peptic ulcer disease. Here we have, if you remember in the beginning, we done the endoscopy, and then we go with the biopsy, and then we found the patient suffer from a Helicobacter pylori. So for the Helicobacter pylori, if you find the patient suffer from Helicobacter pylori, we have two approaches. The most common one for approach, we have triple therapy. 3 medication. 1, 2, 3 medication should be prescribed to your patient. Sometimes we prescribe 4 medication. Okay, so we have 3 medication or 4 medication, depends on the approach. If we have Helicobacter pylori diagnosed with PPI, so patients suffer from peptic ulcer disease plus Helicobacter pylori. How we can treat the patient here, you can see here we have triple therapy and we have quadruple therapy. For triple therapy, proton pump inhibitor, we prescribe number 1, this is medication number 1, 3 medication. Number 2, clarithromycin. Number 3, amoxicillin. Okay, 3 medication. But if the patient has a history of allergic to the penicillin, so we use metronidazole. Okay, PPI, clarithromycin, amoxicillin. If the patient allergic to the penicillin, we add or we replace it with the metronidazole. So 3 medication, and this one should be for 14 days, 2 weeks. Okay. What about quadruple therapy? They said if the patient demonstrates clarithromycin resistance, here, okay, so if we have clarithromycin resistance from the Helicobacter pylori, we go the quadruple therapy. Number 1, we prescribe proton pump twice daily. This is number 1. We're looking for four combination. Okay, number 2, we have bismuth. Number 3, we have metronidazole. Number 4, we have tetracycline. So as you can see here, we have the combination work for quadruple therapy: PPI, bismuth, tetracycline, metronidazole, 4 medication. We have, this is bismuth containing quadruple therapy. We have non-bismuth containing quadruple therapy. Okay, we go the PPI, number 1, number 2, amoxicillin, metronidazole, and clarithromycin. Clinical use of, so we have metronidazole, we have it in, you can see the metronidazole here. Highlight, for example, I will highlight metronidazole, 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 metronidazole. So we have it in 3 places. That means we need to emphasize on this one. What is the metronidazole here? So while we can work with the metronidazole. What they said there, metronidazole, this medication used for treatment of anaerobic infection. Anaerobic infection could be intra-abdominal infection, pelvic inflammatory disease, bacterial vaginosis, or dental infections. Any anaerobic infections, number 1. Number 2, this medication used for protozoal infections such as giardiasis, trichomoniasis, and amoebiasis. Okay, so this is number 2. Number 3, this medication used for management of Helicobacter pylori as a part of triple therapy and quadruple therapy, if you remember that. This medication used for patients from Clostridium difficile infection or colitis. Okay, so you can see here, you can use it for several maybe cases. For metronidazole clinical use, we have the anaerobic infections, protozoal infections, Helicobacter pylori, and Clostridium difficile. Which of the following is or are quadruple therapy for peptic ulcer disease? I will start with D. H2 blocker, PPI, metronidazole, tetracycline. Yes or no? No, because we don't combine 2 and maybe secretory agent. Okay, metronidazole, tetracycline, bismuth, clarithromycin. Okay, we have something missing here. We need PPI. We don't have PPI in this one. It's not correct. Okay, PPI, that's good. Metronidazole, tetracycline, bismuth, that's correct. PPI, clarithromycin, amoxicillin, metronidazole, that's correct. I hope we have the answer. No, we don't have the answer. So the correct answer will be A and B. PPI, metronidazole, tetracycline, bismuth, PPI, clarithromycin, amoxicillin, metronidazole. This is the correct answer. Okay, moving to the guidelines. Speaking about guidelines, treatment for guidelines, I will click on the link, but I have it already in front of me. Okay, for the guidelines. So this one published on website, this website here, I tried to review the website, me and you together. I will follow, maybe scroll down to the guidelines. what we have there for the guidelines, because our topic speaking about guidelines, how to approach patient with the peptic ulcer disease. For example, you can see here if the patients are from ulcer-like symptoms. We look on the is the patient on NSAID. If he said no or yes, if you said yes, and we recommend you to stop NSAID. If not possible, decrease dose. Okay, if you decrease stop NSAID symptom relief, okay, no need for treatment. If the symptom persists, prescribe H blocker or PPI. Okay, move, prescribe H2 and PPI. If the symptoms resolve, okay, continue prescription. If the symptom persists, then move to the beginning here. Go to the endoscopy. So we have process here. I have the link. I recommend you to maybe read this information here and how to approach patient. I think this one will be clinical application during your clinical rotation as a pharmacist, as a medical student, or as a physician assistant student, or as a dentist student. Okay, so we have BUD treatment guidelines. We recommend you to read and maybe the information, be familiar how to approach. At the end of this lecture, I would like to thank you for your listening and watching this lectures, and you get maybe the most benefit, I think, not only from the topic of this lecture, also from the discussion, from the question that delivered in this lecture. Okay, at the end of this lecture, as a recap on summary for what we have discussed already in this lecture, we discussed the peptic ulcer disease. We start with the definition. We go through the physiology, pathophysiology about the parietal cells, and we discuss the receptor available in the cell surface, and we discuss what type of receptor we have there. Histamine receptor, we have the acetylcholine receptor, prostaglandin, gastrin, and the final step of reduction of NSAID like proton pump or hydrogen potassium ATPase. Then we apply our medication on these target cells using the muscarinic receptor blockers. We use the histamine H2 blockers. We use prostaglandin analog or like proton pump inhibitors. If we have increased acidity, we try to use antacid to neutralize the acid. And we have another group of medication called mucosal protective agents such as Sucralfate. We have misoprostol as prostaglandin. Then we have the Bismol as mucosal protective agents. And we discuss the proton pump, and we discuss a lot of adverse effects such as, for example, osteoporosis, such as pseudomembranous colitis. And we discuss with you the interaction with the absorption of ion tetracycline, interaction with the warfarin, diazepam, phenytoin, with both the cimetidine and omeprazole. And we have the option to choose which one of these group H2 blocker or PPI with the least side effect, such as, for example, famotidine, considered less side effect and most potent. Moving to pantoprazole, rabeprazole, considered like most effective and less side effect compared with the omeprazole. So at the end of this lecture, I would like to say thank you for everyone and have a great day.